Welcome you all to INI-CET 2022 Pathology Recall Questions. So this session actually will be discussing what are the questions actually we got from pathology and the related topics in this INI-CET. And to be frank, actually this time also as usual, lot of questions came from pathology and it's a related topic, and the core pathology topics actually were really from more around 25 questions. That is literally from the core pathology topics. Okay. So pathology has its more applied things in other subjects also. That also with that basic pathology knowledge, we could solve all these questions. Okay. So from ADrPlexus, actually, we are very happy to say that actually most of the questions from pathology and the related things, actually, we took it from our workbook based sessions. And you can see that the questions were repeated. The same ditto, the same things actually were asked in the exams. So let us see overall view about analysis about this paper. So how was this paper? Most of you felt that actually it is like a mixed type of paper, like both some easy questions were there and the straightforward questions, and really actually some questions were really complicated. Actually, we don't know, we were stuck where to this thing, and some questions were totally new topics, like which was not touched previously. So it was like as usual, it was a quite decent paper with a mixture of all these things, and those who have prepared very well definitely could get a good score in this INI-CET paper. So it is actually an overall a decent paper, good paper only, according to all of us. Like who did postmortem of the questions after the exams, we felt that actually this is a quite decent paper with the equal number of repeats were there, and some applied concepts, and also image-based questions. So all these things were actually put in equal mixture. And to be frank, this paper also had a lot of image-based questions, not only from pathology, histopathological image, and even people you can will accept that actually even radiology also had some images, all those things. So let us see how the pathology questions were asked, and what are the controversy questions, and how we have to deal about these controversy questions, and what are the future questions which can be asked from this related topics in the upcoming NEET exam. So that is our target should be like that only. So let us see the first question. Toluene blue stain is used to stain. So toluene blue stain is used to stain. So it is actually they are given an image. According to many of you, they are given an image and they have asked this thing. And actually, many of us, many of you told that actually you could identify the diagnosis, you could make the answer even without seeing the image. But all of you will know the answer that toluene blue used to stain the mast cells. The correct answer is the mast cell. Stain, and this stain actually you could see that these are all the mast cells staining this red purple in color, and also red purple in color, and also these are all the stains, background staining, which is blue in color. Okay, blue in color the background, and this is purple. So because of this only, this is a metachromatic stain. Okay, so this is a straightforward question. Okay, so nothing wrong means controversy about these things. Now moving on to the next question, that is cell inside cell appearance is seen in. So the options given for these questions were, according to your recall based things, it is necrosis, necroptosis, apoptosis, and entosis. So actually many of you would have ruled out the options. So definitely cell inside cell appearance will not occur in a necrosis. So necrosis, the cell death will be there. So there will not be any cell inside cell appearance will not be there. And a necroptosis, as you all know, it combines the features of a necrosis as well as apoptosis. Necrosis as well as the features of apoptosis, it combines. So definitely this also will not have the cell inside cell appearance. And the apoptosis, what happens in apoptosis after the apoptotic bodies are formed? It is only the phagocytic, the macrophages. Macrophages will engulf the apoptotic bodies. That you know that efferocytosis occurs. Efferocytosis is the process of phagocytosis of these apoptotic bodies by the macrophages. That all you know. So by ruling out all these options, actually many of you would have made a diagnosis of entosis. So entosis actually some this terminology may be new to some of you, but it's actually quite an old terminology, which is actually previously a very well-known terminology, and now it is actually the Robbins 10th edition has not mentioned about this thing. Means actually it is somewhat outdated things. So entosis is nothing but actually it is a cell And inside the cell, you will have another cell. This is the cell inside cell appearance. So this closely related topic with this entosis is the emperipolysis. So emperipolysis and this entosis are closely related things. But how will you differentiate this entosis and emperipolysis? This I am discussing because upcoming NEET exams, this may be a related topic, so that may be asked. So let us see how this goes on. So emperipolysis also is like actually passive phenomenon. So in which the cell, large cell, say for example, the large cell in the bone marrow, that is a megakaryocyte. Inside the cytoplasm of the megakaryocyte, you can see the smaller cells like neutrophils, lymphocytes, that is inside the cytoplasm. So actually these cells are actually living cells. These cells are just both are living cells, megakaryocyte as well as the cell which is inside the megakaryocyte, that is a lymphocyte or neutrophil. Both are actually living cells. So it is just a transient process of the cell towards that large cell. So this is emperipolysis. But entosis is nothing but actually this occurs when there is a loss of the intercellular connections. When the neighboring cells, intercellular connection, you know that intercellular connection via this E-cadarins. So this E-cadarins, when there is a loss of this E-cadarins, and there will be yes, cell, winner cell, you call that as a winner cell and you call the other cell as a loser cell. The winner cell will try to engulf, will try to swallow this loser cell. So what happens? The cell goes, the loser cell goes inside to the winner cells. Okay, so winner cell, actually why this mechanism occurs? Actually this mechanism occurs mainly in tumor tissue, mainly occurs in cancer. These cells actually occurs in cancer. Why this occurs in cancer now? Because the cancer cells actually this entosis as a role both as a anti-tumorogenic or also favors tumor. So it has a dual role. How it can serve as an anti-tumorogenic, anti-cancer. That means these cells, the winner cells actually will be engulfing this loser cell, that is the E-cadarin. Without loss of this E-cadarin, this winner cell will have an entosis, thereby the tumor cells are killed. And somehow it favors the tumors. How it favors the tumors? That means the tumor cells will be having deprived of nutrition. Usually the tumor cells will be deprived of nutrition. So what happens? Because of the lack of nutrition, the tumor cells try to get energy, try to get its nutrition by entosis of the neighboring cells. So thus this entosis, because of the loss of cadarins of the adjacent cells, favors both tumor as well as it fight against the tumor. So it has a dual role, like your autophagy. Okay, so these things were quite discussed in our workbook, and you could see that we discussed about this necroptosis and the other things also. Okay, so now the next question is, all of the following are true about renal clear cell carcinoma except. And actually there are quite a discussion. Actually many students were saying that so it is not all are except, and some were saying that it is like which is true, like that it was asked. Actually here if you see, two options, out of the four options, two options were correct and the two options were really wrong. So actually many of you could not some of you could not recollect like how this question was framed. So let us discuss each options one by one and we will come to a conclusion, so that actually this will help us in solving the future MCQs. Okay, so if you see about this renal clear cell carcinoma, most of the renal clear cell carcinoma is sporadic in nature. Okay, sporadic in nature, and you know the chromosome involved in this renal clear cell carcinoma is a chromosome 3, and you know it is a VHL gene. VHL gene only know that we want Hippel Lindau gene. So VHL gene. So they have mentioned the second statement as long arm deletion. Actually, it is in VHL, it is 3P deletion. 3P deletion is nothing but 3 short arm deletion. 3 short arm deletion is the correct process which is occurring in renal clear cell carcinoma, short arm deletion. But here they have mentioned it as one option, it was mentioned as long arm deletion. So this should be a wrong statement. Okay, this should be a wrong statement, and the first one, sporadic, is the right statement. And all of us will know that this renal clear cell carcinoma arises from the proximal convoluted tubule. arises from the proximal, this clear cell carcinoma arises from the proximal convoluted tubule. And we were quite sure that the third option was it was given as it arises from the distal convoluted tubule. So this obviously is also a wrong answer. And why this name clear cell was given to this carcinoma? Because it is cytoplasm is clear. We have read from our discussions in our work-based teaching that actually this any cell which is clear must contain either a glycogen or a lipid. So glycogen or a lipid. So you can see this option, that is a tumor cells in the renal clear cell carcinoma containing glycogen and lipid, is a correct option. So in this question, if you can see that there are two correct options and there are two wrong options. So we don't know, like I could not exactly make out the answer, like how the answer was framed, like option A and B correct, B and C and D wrong, or like that. But this is the correct, these are the options and this is the true nature of each options. That is, it is sporadic in nature and the tumor cells contains glycogen and lipid, and clear cell carcinoma there is 3p deletion will be there, that is short arm deletion will be there, and it arises from the proximal convoluted tubule. Okay, so you could see that actually these are all actually discussed in our MCQ based, this workbook based teaching in our ADrPlexus. You can see that we have discussed all this 3p loss and this clear cytoplasm and the sporadic nature of this tumor. Okay, so the next statement, next question is, which of the following is true about autophagy? So autophagy, we quite discussed in our work-based. We discussed a lot about this autophagy, and we told that it is a 10th edition of Urbans. This is a newly updated topic, and there is a more chance of coming in the exams. So as expected, this topic definitely, it's not a quite surprise for us. Actually, we expected this topic to come in the exam. So the examiner also asked this. Autophagy. So there are some statements about the autophagy, and the examiner asked about, like, which is the following is the true about the autophagy, and the options were actually taken from all the recall based, your memory based options only. So let us see, even if you want to change anything, you can put it in the comment box about discuss the options. So let us see each option one by one. The first option was activated, the autophagy is activated when there is excess protein gets aggregated inside the cell. What do you think about this option, whether this is true or false? That is, when there is excess protein inside the cell, why autophagy should occur? Autophagy is eating up its own cell contents. When there is excess nutrition, when there is excess protein inside a cell, why the cell should go for autophagy? Why it should digest itself? When during a nutrition deprivation only, the cell want to survive. As an adaptation, it tries to do autophagy. So when protein content is excess, definitely cells will not go in for autophagy. So this option is wrong. Second option, autophagosomes can fuse with any cell organelles. Autophagosome can fuse with any cell organelles. So do you think that autophagosomes can fuse with any cell organelles? Usually, autophagosomes will fuse with the lysosomes only. So usually these autophagosomes will fuse with the lysosomes only, and these lysosomes only will be, after fusing, it will be forming this autophagolysosome. So autophagosomes will not fuse with any organelle, it will fuse with only with the lysosome. So this option is wrong, and obviously the third option is the right option. That is, it fuses with the lysosome to form the autophagolysosome. And also, if you could see the fourth option, they mentioned that it is a single membrane bound structure. No, autophagosome is not a single membrane bound structure. It is a double layered membrane bound structure. Okay, so if you can turn the pages of ADR workbook, actually you can see that all the things we have discussed about the autophagy and what are the different types of autophagy and what is its role in the other pathological conditions. Okay. And the next question, the differential expression of the genetic material in parents is called as, and the options which were given in this thing is mosaicism, partial penetrance, genomic imprinting, anticipation. So what is this differential expression of the genetic material in parents? So that means there are some genes, there are the genes which are actually imprinted, which are just actually imprinted, that is mean silenced in a specific parent. There are certain genes which are expressed only in a certain parental thing, and this phenomenon is called as the genomic imprinting. This phenomenon is called as the genomic imprinting, and we have quite discussed with this in our workbook based thing. That is actually, you could see the notes of this, that it is a preferential expression of one of the parental alleles. We know no, for each gene expression, there should be two alleles. But what happens when there is a preferential expression of one of the parental alleles? That means only one parental allele will be expressed and the other parental allele will be silenced. The process of the silencing is the imprinting. So imprinting is nothing but the process of the silencing. That is, maternal imprinting means there will be transcriptional silencing of the maternal allele, and paternal imprinting, you have this paternal allele will be silenced. Okay, and we know about this genomic imprinting disorders. When there is a maternal deletion, you have this Angelman syndrome, and when there is a paternal deletion, you will have this Prader-Willi syndrome. So genomic imprinting is the correct answer, in which there is a differential expression of the genetic material in the parents, and you have two disorders, that is the Prader-Willi and Angelman syndrome. So what is this mosaicism? Mosaicism is nothing but in a single individual itself, there will be different types of population of the cells. Say, for example, I can say in Turner syndrome or in Down syndrome. So what happens in Turner syndrome? Some cells will be having 45X0 pattern, cells will be having 46XX, and other will be having a normal type. So there will be this mixture of the cells of two different pattern is called as a mosaicism, mosaic pattern. Okay. Then coming to the other option, that is a partial penetrance. Partial penetrance is nothing but how the phenotype is, how the deleted gene, how the mutated gene expresses the phenotype. That is, whether if 100 people are carrying, the gene mutation, out of this 100 people who are carrying the gene mutation, how many of them actually express the phenotype? How many of them express that characteristic phenotype? That is the penetrance. So partial penetrance means, that is, not 100 people also who carry the mutated gene will not express the phenotype. Only few of them, say for example 60% or 70% only will be having that expression. So they only the mutated gene has its expression. So this is called as partial penetrance. Okay. Then coming to the last option, that is the anticipation. So what is anticipation? Where you read about this anticipation? Yes, very good. It is a Fragile X syndrome. You will have the phenomenon of anticipation. So what is anticipation? As in the subsequent generations, as you go in the subsequent generations, the disease severity increases. The severity of the disease increases. That is, father will be having more severe disease than the grandfather, and the grandson will be having more severe disease than the father. So as the generation goes on, the severity of the disease increases. So this is the phenomenon of anticipation. So coming to our question, that is the differential expression of the genetic material in parents is called as genomic imprinting. Yes. Now coming to the one of the controversy questions. And the question was asked, like a 72-year-old man presented with a hip pain. And some people were telling that it is a knee pain or hip pain. It can be both, knee hip pain or knee imaging. The age is also 72 years. And if you could see that, and they have given actually histopathological image. So I could not have an idea of like what is the exact type of image asked. So with this history, first itself we'll have a thing, old age. So old age with reduced joint space. And if you could see the first thing in the old age with reduced joint space, first thing will be striking in our mind is osteoarthritis. And if it is a male, usually this hip joint or the first involved joint. Yes. Osteoarthritis in males, usually hip joint is the most commonly involved joint, and in females it is the knee joint and the hand joints. Okay, so in females osteoarthritis involves the hand joints and the knee joint, whereas in males the hip joint is the most commonly involved joint. Okay, so with the age related factor and the involvement of the joint with age, and also with the reduced joint space, what we will see, like what image would have been given if it is a case of osteoarthritis. Osteoarthritis, you can see this is the joint surface, articular joint surface, and what will happen this in the articular surface, there will be proliferation of the chondrocytes. there will be proliferation of the chondrocytes, and there will be edema. There will be edema fluid which will be collecting in the joint spaces, okay, in the joint cartilage. So what happens because of the collection of the edema? There will be fibrillation occurs, okay. Fibrillation of the articular surface occurs. So later after the fibrillation, you will be getting this, what is called as loose bodies. So loose bodies, okay, that fibrillation will separate the cartilage, and small loose bodies will be there at the articular surface in the joint space. So fibrillation of the articular cartilage and the loose bodies will be there in the case of osteoarthritis. So if the image given to you is similar to like this, of the articular joint surface with this fibrillation and some kind of loose bodies like this things, actually you would have thought of this osteoarthritis, okay, with the image thing. But actually quite some of you were confused with rheumatoid arthritis, whether it can be rheumatoid arthritis. If the histopathological image, first option based on the history, we have to go in for osteoarthritis only, okay, with the history of 72 years old, reduced joint space and hip joint, if it is there, then we have to go a diagnosis of osteoarthritis only. But if the image is given something like this, like say for example, the synovial biopsy is thrown into papillary folds. See this, these are all the papillary folds. So if the synovium is thrown into papillary folds, that is, and these papillary folds also will be containing lot of inflammatory cells, especially this plasma cells. Plasma cells, yes, plasma cells. So plasma cells, what you will be having this eccentrically placed nucleus. Okay, plasma cells, you will be having this eccentrically placed nucleus and a perinuclear hollow. So if you could see this in this synovial biopsy, lot of plasma cells and thrown into papillary folds, and you will be getting so-called the Pannes formation. If this Pannes formation is characteristically given in your question, you have to think of rheumatoid arthritis, okay, rheumatoid arthritis. If there is a Pannes formation, then what is this thing characteristic of this rheumatoid arthritis? You could see a central necrosis. If you could see a central necrosis, and surrounding this necrosis, if there is an arrangement of histiocytes in a palisading manner, that is, histiocytes arranged in a palisading manner around a central necrosis, and this phenomenon is called as palisading granuloma. Yes, if the histological image is given like that of a palisading granuloma, then also your diagnosis will be rheumatoid arthritis. So your diagnosis will be rheumatoid arthritis if the histopathological image showed you this synovial papillary foldings and plasma cells with the Pannes formation and palisading granuloma. If any of these findings are there, then your diagnosis will be rheumatoid arthritis. Or else, if the given picture is like this kind of things with the characteristic history, the first option we'll go for is osteoarthritis. And tubercular synovitis actually definitely will be having. If the examiner want you to identify the tubercular synovitis, definitely he would have given you the image with the granuloma with a lot of histiocytes and giant cells. If you could see the giant cells, lot of giant cells with the granuloma formation with epithelial histiocytes, then you would have made a diagnosis of tubercular synovitis. But with this preference in this thing, osteoarthritis, without any image, the diagnosis of this case will be going in for osteoarthritis, and with the image, based on the image finding, this will be the diagnosis. And Lyme's arthritis will not have any specific like among these things, okay. Now moving on to the other question. This questions actually many students were saying that so NK cells means first we thought that it will be only the CD16 and the CD56. So all of us will be tuned to that CD16 and the 56 only. So the examiner knows that all of you know these things. So this time he wanted to ask a different kind of things about the other markers which are positive in this NK cells. So he has given the 4 options, okay. So the first option is CD94, second is CD3 and CD25, and fourth one is CD6. All of you will be ruling out the CD3 because it is a T cell marker. So CD3 actually will be a T cell marker and will be negative in NK cells. So it is because of this only NK cells are also called as null cells, because it doesn't express any T cell marker or B cell marker. So CD25, actually it is a marker for this T regulatory cells which suppress this autoimmunity. So CD25 is also ruled out. It is a positive for this T regulatory cells. And CD68, which is a macrophage marker, and definitely it is not an NK cell marker. So CD68 is also rolled out. So, and please remember students, it is CD94, which is actually a NK cell marker. CD94 is expressed in the NK cell. And actually these cells are called as, these receptors are called as activating receptors. We have quite discussed in our workbook that it is NKG 2D receptors. These receptors, these NKG 2D receptors is the CD94. CD94, these NKG 2D receptors. Actually, if you remember, we discussed in our workbook that actually these receptors will be recognized in the surface molecules which are expressed in the during the stress and in the infection. During the stress and in the infection, these markers are expressed. So CD94 is nothing but it is the NKG 2D receptor, which is an activating receptor. So the correct option here in this thing is CD94. Okay, so this is actually quite a familiar topic, but a new type of information the examiner is asking from you, and quite we have discussed that new information in our also work-based teaching. Okay, this is the thing. Then all of the following clotting factors are elevated in pregnancy. Okay, except if you could see that most of the clotting factors are elevated, it is a straightforward question. All of the clotting factors are mainly elevated in the pregnancy, except the answer for this. This is a straightforward question, and the answer for this is factor 11. So factor 11 is actually decreased in the pregnancy. The rest of all these things are elevated in the pregnancy. The next question is, actually this is also a straightforward question. Which of the following disorder is X-linked dominant disorder? So usually in our teaching, actually I used to influence that, highlight that, please remember at least in exams, any one of this example for autosomal dominant, autosomal recessive, X-linked dominant, X-linked recessive, actually these examples are quite frequently asked in most of the exams. So it is a quite repeat topic, and that also we stressed during our teaching. And you could see that in our workbook, actually we have dealt with this X-linked dominant disorders, and we have marked this Rett syndrome. So the answer quite common in this thing, X-linked dominant disorder. The answer for this question is Rett syndrome. So other options like ornithine transcarbamylase deficiency, tuberous sclerosis, Duchenne muscular dystrophy are not X-linked dominant. So how will you, what are all the X-linked dominant disorders? Usually this vitamin D resistant rickets, X-linked hypophosphatemia, hypophosphatemic ricket, Rett syndrome, incontinentia pigmentae, and Alport syndrome. So these are the conditions actually which are inherited in an X-linked dominant fashion. Then the next question is, a 45-year-old female presented with easy fatigability, pallor. So a female presenting with pallor and fatigability. So you will think of anemia. So easy fatigability and pallor, you will think of anemia. And the hemoglobin was 6 gram per deciliter. So hemoglobin was very low. Okay, hemoglobin given is very low, like 6 gram per deciliter. And the examiner is asking you what is the most likely finding in the peripheral smear. So the options actually they are recollected from the memory of microcytic hypochromic, macrocytic hypochromic, target cells, and poikilocytosis. Actually, there is a quite overlap among these options, and in this question we have to choose the best among the four. Target cells is actually a non-specific finding. It can be seen in even in an iron deficiency anemia, thalassemia, and it is a non-specific finding. Hemoglobinopathies also you can see this target cells. So it is a non-specific finding, target cells. And poikilocytosis just tells you that there is a difference in the shape. There is difference in the shape of the RBCs. Yes, poikilocytosis can occur in iron deficiency anemia and even can occur in thalassemia and in any other conditions also, the poikilocytosis. And definitely your diagnosis, your thinking will not be in a term of a macrocytic anemia in a female with a hemoglobin 6. First thing, you will not think of a macrocytic anemia. So usually what you will be thinking in this females presenting with this easy fatigability and pallor, the first thing we'll think of is microcytic hypochromic anemia, and the most commonly cause of this microcytic hypochromic anemia in our setup is the iron deficiency anemia. So yeah, common thing, remember students, common things are common. So when you make a common diagnosis, definitely most of the time you will be right only. Okay, so the common things, first think logically, and instead of going in for target cells and saying that in iron deficiency anemia also target cells will be there, hemolytic anemia is also target cells will be, yes, it will be there, but which is the commonest one? Usually the iron deficiency anemia is the commonest one, and so we have to choose the option of microcytic hypochromic anemia. That is cause of this iron deficiency anemia in this patient. Yes. So the next question is, which of the following is not seen in pleomorphic adenoma? So pleomorphic adenoma, all of us know that it is a benign tumor. So it is a benign tumor actually with a mixed tumor. Why it is called a mixed tumor? Because it has both epithelial and this mesenchymal differentiation like thing. So mesenchymal differentiation, definitely, as you know that the stroma, the supporting stroma, the stroma of the tumor will be like a chondromyxoid, chondroid and a myxoid. So the option of chondroid differentiation holds correct. So it is seen. It is seen in pleomorphic adenoma. Myoepithelial cells, yes, myoepithelial cells will be definitely there in case of a pleomorphic adenoma, definitely. So this is also a thing. So actually what many students got confused is they got confused between the two options, that is a perineural invasion and the keratin pill formation. So coming to these two options, keratin pill formation. So first thing you will think of this keratin pill formation is it is like it is seen in squamous cell carcinoma. Keratin pill formation is seen in squamous cell carcinoma, but keratin pill formation is a non-specific finding. So wherever there is a squamous epithelium, that squamous epithelium will start producing the keratin. Do you think that in a mixed tumor it will not have any squamous epithelium? Definitely the squamous epithelium will be there. Squamoid differentiation will be there in pleomorphic adenoma. And there can be a squamous metaplasia that can occur in a pleomorphic adenoma. Squamous metaplasia or squamoid differentiation. So there are many articles which are favoring this thing, that is a squamoid differentiation and a squamous metaplasia occurring in a pleomorphic adenoma. And definitely these things will produce the keratin pill. Okay, so please take it from your mind that the keratin pills are not very specific for squamous cell carcinoma. It can be seen in any other condition which has this lot of squamous epithelium. So wherever this squamous epithelium is there, it will be starting producing this lot of this keratin formation. So keratin pill formation can be seen in pleomorphic adenoma. So this option is also correct option. So which is not seen is pleomorphic adenoma is this perineural invasion. You can imagine, no, like a perineural invasion, actually it is a feature of malignancy. Like adenoid cystic carcinoma and minor salivary gland tumors, actually they have prone for this perineural invasion. They infiltrate the deeper tissues. But pleomorphic adenoma, most of the times it is a benign tumor. So it is a benign tumor. So perineural invasion is not a very classic feature. Or how can be a feature of a pleomorphic adenoma, which is a benign tumor? Perineural invasion will not be usually seen in a pleomorphic adenoma. So the option we have to choose in this question is perineural invasion. Perineural invasion. Yes, this is the option we have to choose. This is seen, this is seen, this is seen, and perineural invasion will not be seen in pleomorphic adenoma. Yes. And moving on to the other things, other question. Neurosecretory bodies are seen in all except. So what are these neurosecretory bodies? These bodies are nothing but they will be containing the neurosecretory granules inside the cytoplasm of the cell, especially in this neuroendocrine tumors. Inside the neuroendocrine tumors, the cells will be having a lot of these neurosecretory granules, and these granules will be containing all these enzymes or hormones that will be releasing the things, releasing the tumors. Okay, so this only will be giving you this in the histopathology. This neurosecretory granules only will be giving you this salt and pepper chromatin. So if you can see this, most of the neurosecretory bodies, neuroendocrine tumors will be having this salt and pepper chromatin in the histopathology. And similar, this thing will be seen in the electron microscopy as a dense black granules, dense black granules as the neurosecretory granules. Yes, coming to the options. Medullary thyroid carcinoma. Yes, definitely this medullary thyroid carcinoma is a of this neural origin, like, and definitely it will be having this calcitonin as the tumor marker. Yes, so neurosecretory bodies are seen in this medullary thyroid carcinoma, and the pituitary adenoma. Yes, it has a lot of secretory function. All these things, no, growth hormone, prolactin, ACTH, and steroids. All these things will be secreting. So pituitary adenoma will also have this neurosecretory bodies. Okay, and paraganglioma, and you remember this paraganglioma of pheochromocytoma has a lot of this marker VME, and all these bodies will be hormones will be produced. No, so this is a quite actually common to see neurosecretory bodies in this paraganglioma. You remember the example of a pheochromocytoma. So what is usually not seen in this thing neurosecretory bodies is the adrenal cortical tumor. Okay, so adrenal cortex will not have that much of secretory function compared to an adrenal medulla. So the tumor arising from this adrenal cortical cortex will not have such this neurosecretory bodies. So the option we have to choose here is the neurosecretory bodies are not seen in adrenal cortical tumor. Adrenal cortical tumor. And if you could see this, we have highlighted this point when we in our workbook in the topic of pheochromocytoma. So the next thing, which is a very easy and a very straightforward question, that is which one of the following is the familial? Familial. So out of these four options, that is a retinoblastoma, retinitis pigmentosa, myopia, primary open angle glaucoma, the most all of us will know that retinoblastoma is the familial in inheritance. Retinoblastoma is familial inheritance. So it is a very straightforward questions, and without wasting much time, we'll go on to the discussion of the other questions. And usually, if you could see that we have highlighted in our workbook that actually about the familial nature of the retinoblastoma, its location in the chromosomes, and about the sense two hit hypothesis and its role, how the mechanism in the tumorogenesis, all these things actually we have discussed in our workbook. Then the next question. Screening of all the infections are required before blood transfusion, except screening of all the infections are required before blood transfusion, except. So if you could see that NACO in all our blood banks, NACO suggests the screening of 5 infections, mainly the 5, all the blood products should be transfused should be screened for this 5 infections, especially this HIV, hepatitis B virus, hepatitis C virus, malaria, and syphilis. Okay, VDRL for this syphilis. So these are the 5 things that is the any blood product should be screened according to the National AIDS Control Organization, that is the NACO guidelines. Actually, usually we will not screen dengue virus, dengue infection in the blood product should be to be transfused. Okay, so malaria will be screened, hepatitis B will be screened, and HIV will be screened, and dengue will not be screened. So the correct option here we have to choose is the dengue. Moving on to the next question. That is also a very straightforward question, and it is like a very much lucky question for all of us. Like MHC1 binds to which of the following? Okay, so if you could recollect what we have discussed during our workbook based teaching, you could see we highlighted the factors that CD4 cells binds with the MHC2 complex, and the CD8 cells binds with this MHC1 complex. Okay, so and I told you to remember the mnemonic. If you multiply everything, it should come as 8. Okay, you remember that I told the mnemonic. So CD4, that is 4 into 2, 8, and 8 into 1, 8. Okay, so CD4 cells will bind with MHC2, and the CD8 cells will have this binding with the MHC1 complex. So the correct option here is MHC1 binds to CD8 cells, CD8 cells. Then this is also a straightforward question. They match the following about the carrier proteins and what is the hormone or the substance which it is carried. So the correct options among this thing, actually I have arranged this question in a correct option manner. So all of us will be knowing this thing. Prealbumin will be carrying this thyroid, and albumin carries this fatty acid, and haptoglobin will be the carrier protein for this hemoglobin, and hemopexin will be carrying this heme. So this the examiner given in a form of match the following sort of things, and wanted you to pick up the correct options. Okay, so prealbumin thyroid, albumin fatty acid, haptoglobin hemoglobin, and hemopexin is heme. Yeah, again, there's a lot of things going about these questions. Banding technique used in dicentric chromosome. Banding technique used in dicentric chromosome. So this, if you could remember, we have discussed in detail about this banding technique during our workbook-based teaching. We have discussed about different type of banding: G banding, R banding, Q banding, and C banding. There I highlighted these things. And if the question is just banding technique commonly used in this karyotyping, if the question is just like that, we definitely will be choose this G banding. Yes, because G banding is nothing but actually it is a GIMSA banding, which is a commonly used banding. And here it will be the staining about the different arms will be staining this bands, sub-regions, all those things it will be there. Okay, so it will be staining in this thing. Usually it will not actually have a staining in the centromere region. Usually it will not have staining in the centromere region. So if the examiner, why they have specifically given this word dicentric chromosome, dicentric chromosome. So dicentric chromosome is nothing but which will be having the two centromeres, okay, which will be having the two centromeres. So it will be, there will be two centromeres, and these two centromeres will be having this, the centromere region will be heterochromatin. The centromere region will be having this heterochromatin, and usually G banding, that is the GIMSA banding, will not stain this centromere, but only to stain this centromere or to stain this heterochromatin, what banding is commonly used? Commonly used is C banding. Commonly used is C banding. Please remember, though GIMSA banding is used commonly, that can stain this different bands and sub-bands, regions, and all these things, usually it will not stain the centromere. Usually it will not stain the centromere because of the heterochromatin. So what is specifically actually for this dicentric chromosomes? Dicentric chromosomes which will be rich in this thing, heterochromatin. Actually, the centromere, if you want to highlight the centromere, if you want to highlight the centromere, then only you can say that this is a dicentric. You can easily say, study the region of the centromere. So for this thing, for studying the centromere, actually in the case of a dicentric chromosomes, we will prefer to use C banding technique. Okay, so here the C banding is preferred over GIMSA banding because C banding is something specific for this staining this dicentric chromosome. G banding is a G banding is an overall staining, but for studying this dicentric chromosomes, or the examiner would have directly asked like what is the commonest banding. If they asked, you could have choose this G banding, but he has specifically asked about the dicentric chromosome. That means he wanted to highlight the centromere. So the banding which should be used here is the C banding. C banding, yes. Then the next question, the image which all of you are familiar when we read about your workbook based learning, and the histopathological image of the ovarian tumor shows the following finding. What is the most likely diagnosis? And the examiner has directly given you the image similar to this kind of image. And if you could see from our workbook, actually we have discussed about this image. That is, this image are called as, these bodies are called as Schiller dual bodies. Yes, we have discussed that this is a Schiller dual bodies. And this other name for this Schiller dual bodies is the glomeruloid bodies. Glomeruloid bodies. What is this Schiller dual bodies or glomeruloid bodies? It is nothing but surrounding a blood vessel. See, this is the blood vessel, and surrounding the blood vessel, you have the tumor cells arranged in a concentric manner. The arrangement of the tumor cells in a concentric manner surrounding a central blood vessel is called as the Schiller dual body or the glomeruloid bodies, and this is characteristic of this yolk sac tumor. Characteristic of this yolk sac tumor. Okay, yolk sac tumor. And obviously, you know, it is occurring in the very younger age group, around 3 or the 2-year-old child or 3-year-old child presenting with the ovarian mass or the testicular mass. You think of this yolk sac tumor. And this is the Schiller dual bodies, which we have highlighted many times. Yes. Then this question, actually the examiner given the image of your skin, histology of a skin structure with the epidermis and dermis, and the examiner has highlighted the various adnexal structures like a hair follicle, say for example a hair follicle, and this is the sebaceous glands, and this is the sweat glands. And the examiner asked like what is an example of a merocrine gland. So merocrine gland. What are this merocrine gland? Merocrine gland are nothing but actually these merocrine gland will be secreting their secretions. Nothing will happen to the cell during the secretion. They will be secreting their secretions into the lumen. So they will be pouring, the cells will be pouring the secretions into a ductular system, and from there the secretion goes on. The cells will empty the secretions through the duct, and such cells are called as merocrine. But other type of thing that merocrine glands, the example, classical example is the sweat glands. Okay, sweat glands and salivary gland. Okay, so salivary gland and the sweat glands. Okay, salivary glands and the sweat glands, especially this eccrine sweat glands. So eccrine sweat glands and the salivary glands are the classical example of this merocrine glands, where the secretions are emptied into the duct and passed into the lumen. But what is apocrine gland? The questions which can be asked in the future things is, what is apocrine gland? That is the secretions. The secretions will be pinched off. The cell, part of the cell will be pinched off. Part of the cell will be pinched off from the during the secretion. That is, the cell part is partly lost in during this apocrine glands in the apocrine secretion. And what is holocrine? Holocrine is nothing but the cell is totally damaged. Okay, the cell is destroyed. That is, the cell is, after releasing the secretions, the cell goes in for death. Okay, so the such things secretions are called as holocrine glands. Okay, so actually you have to remember these three type of secretion, that is the merocrine, apocrine, and holocrine. Okay, now the next question is, all of the following are AIDS defining tumors, and the answer for this is actually the sweat glands, and the answer for this is sweat glands. And the sebaceous glands will be present adjacent to this hair follicle. Sebaceous glands will be present adjacent to the hair follicles. Okay. And this sweat glands will be of two types, apocrine and eccrine sweat glands. I told it is eccrine sweat glands. See, eccrine sweat glands will be having smaller lumen. Eccrine sweat glands will be having smaller lumens, and these sweat glands only are called as merocrine glands. Whereas apocrine sweat glands will be having a bigger lumen. This is also a question future exams it can be asked. Apocrine sweat glands can be of two types, apocrine sweat glands and eccrine sweat glands. So eccrine sweat glands will have a smaller lumen, whereas the apocrine sweat glands will have a bigger lumen. That's how you differentiate these things. Actually, the examiner has marked eccrine sweat gland. So we have to, this is the example of merocrine gland. Coming to this question, all of the following are AIDS defining tumors, except the options are given are Kaposi sarcoma, cervical carcinoma, melanoma, and non-Hodgkin's lymphoma. And quite we all of us know that, and in our workbook also we have discussed about the different types of malignancies, which is the AIDS defining neoplasms. We have discussed about all these things, and we have quite exactly the same thing actually we have discussed. Burkitt's lymphoma, CNS lymphoma, Kaposi sarcoma, invasive cervical carcinoma, and the options were quite similar. Yes, the same thing. So Kaposi sarcoma is a AIDS-defining tumor, cervical carcinoma is a AIDS-defining tumor, non-Hodgkin's lymphoma is a AIDS-defining tumor, but melanoma is the odd man out here. So melanoma is not a AIDS-defining tumor. So this is the answer here we have to choose. Which is the correct ratio of T cell and B cell ratio in the blood? T cell into B cell ratio in the blood. If you remember our workbook based sessions, actually this also we have discussed in our workbook session, that actually T lymphocytes constitute about 60 to 70% of the lymphocytes. Yes, so T lymphocytes will be constituting about the 60 to 70%. Okay, 60 to 70%. And B lymphocytes actually it is around some 10 to 20%. 10 to 20%. So the ideal T cell to B cell ratio here will be like, if you take 60:20, then the correct option here will be 3:1. For every 3 T cells, you will be having 1 B cell. Okay, 1 B cell. So the correct option here is the ratio of T cell is to B cell in the blood is 3:1. Actually, you have 60% of this T lymphocytes, and you can see that from our notes. Yes. The next question is, all of the following are components of innate immunity except The options given are B cells, defensins, complement, gamma delta T cells. And we have quite discussed in our workbook about this topic also, that we have discussed the different types of cells of innate immunity. The different types of cells of innate immunity are epithelial barriers, MALT, macrophages, dendritic cells, NK cells, and complement proteins. Yes. So coming to the options here, defensins, yeah, complement, gamma delta T cells, all these are components of the innate immunity, and definitely B cells is not going to be an innate immunity. Definitely B cells, which will be differentiating into plasma cells and producing the antibodies, these cells are coming under the acquired immunity. So we have to choose the option of B cells in this question. Yes. Yes. This question, this is an image-based question, and the history also like very non-specific, like the male patient present with a history of cholecystitis. Male patient with a history of cholecystitis, that is inflammation of the gallbladder, underwent a surgical resection of the gallbladder. And the gross appearance of the image is shown in the picture. And what is the most likely diagnosis was asked. And quite actually many students were not able to tell like the exact thing, that was a single mass or multiple masses or this thing. So how we'll be discussing this question is, I have given you these three images. Okay, we have given you the three images, and see this image. So in this image, this is an image of a gallbladder, and you can see in this image, you can see multiple yellowish specks. Can you see? This is multiple yellowish specks. So if the examiner had given this type of image, that is a mucosa of the gallbladder showing this multiple yellowish specks like thing, and what is this yellowish specks? Wherever yellow, what I told you, should first think of is fat. Okay, so this is actually this cholesterolosis, otherwise called as the strawberry gallbladder. So both these options point to the same diagnosis, that is the cholesterolosis is the other name for this strawberry gallbladder. So definitely actually the examiner has given two options with the same terminology. So definitely I personally feel that the examiner would not have given this image. So the other two options which we are stuck with, this is polyp of the gallbladder and a carcinoma of the gallbladder. Carcinoma of the gallbladder. So actually, if you could see that carcinoma of the gallbladder can arise in the background of a chronic cholecystitis, and even polyp of the gallbladder also can cause a chronic cholecystitis. So it entirely depends on the interpretation of the image. From the history, we could not get a better diagnosis. So we have to see the image. How? See this. If there is a single mass, like this polypoidal nature, you can think of this polyp of the gallbladder. But also I have to tell you that polyps of the gallbladder can be multiple also. Polyp of the gallbladder can be multiple lesions in the gallbladder, and the carcinoma can arise in the background of a polyp also. That also you have to keep in mind. But generally, as a rule, if you could see this one polypoidal, like this projection like this thing, first think of polyp. If it is an infiltrating mass like this thing, typical picture like that given in the Robbins, infiltrating mass occupying the entire gallbladder. Can you compare this thing? So this is the polyp, and this is a carcinoma of the gallbladder. You could see this in the polyp. Actually, only one area it is that there is a projection thing usually. But if you could see here, the tumor is occupying the entire lumen of the gallbladder. So it is a diffuse infiltrative nature. If the lesion was there as a diffuse infiltrative lesion, so you have to make a diagnosis initially as a carcinoma of the gallbladder. So it's entirely dependent on diagnosis, entirely dependent on the gross image given. And you have to, next time in such sort of question comes, actually you have to interpret based on the logic which I'm giving you now. Okay. Yes. The next question is, a 15-year-old boy presented with a bone tumor in the left upper tibial diaphyseal region with periosteal reaction. Yes, what are all the things? 15-year-old boy, region tibia, and in the diaphyseal region, and with periosteal reaction. Though periosteal reaction can be a non-specific finding, can be seen in many tumors, but it is quite commonly seen in one of these options. And histopathological examination, lesion showed sheets of small blue round cells So you could see, and the examiner also given you the image, this small blue round cells. There are quite a many differential diagnoses for this small blue round cells, and the examiner also given you this many of this very common diagnosis of this in such age group. Small blue round cell, small cell osteosarcoma, neuroblastoma metastasis, Ewing sarcoma, and chondroblastoma. So out of this, actually many are coming as a DD for the small blue round cell tumor. So now let's move on. What else the clue the examiner has given? The examiner has given these are positive for MYC2 and synaptophysin. So positivity of these cells for MYC2 and synaptophysin rules out two options. That is small cell osteosarcoma and chondroblastoma. So many of you will be now confused between these two options, Ewing sarcoma and neuroblastoma metastasis. But please remember, the small blue round cells, in the case of this 15-year-old boy, common things are common. Okay, so please keep in mind, diaphyseal region. So the examiner has given you clearly it is a diaphyseal region. So diaphyseal region, periosteal reaction, 15-year-old boy, in the background of small blue round cells, first thing you will be thinking of is Ewing sarcoma. Yes, Ewing sarcoma, MYC2 positivity. This is confirmed by MYC2 positivity. Many of you got confused why they have given the option of synaptophysin. Will synaptophysin will be positive in Ewing's or not? That is a question many of you had asked me. And many of you also told that synaptophysin actually, why can't it be a neuroblastoma metastasis because it is synaptophysin? But please remember, in Ewing sarcoma with neural differentiation, yes, Ewing sarcoma with neural differentiation definitely will be having synaptophysin positive. Okay, will be having synaptophysin positive. Okay, so with the age and the diaphyseal region, usually like metastasis, why the examiner should ask you like only specify diaphysis? If the examiner wanted you to choose neuroblastoma mets, why he will be giving this only that region of diaphysis? Actually, but even commonly the diaphysis is it is a diaphyseal lesion, no? So Ewing's it is a diaphyseal lesion, and MYC2 it is commonly positive for this thing, no? Ewing's, no? And Ewing sarcoma with the neural differentiation definitely will be positive for synaptophysin. And I would like to prefer make a diagnosis of Ewing sarcoma in this case rather than the neuroblastoma metastasis. Okay, so and you could see these are the small blue round cells with this clear cytoplasm, and also this what special stain actually this will be positive. This also will be positive for PAS. Okay, these tumor cells will be positive for PAS because it contains the glycogen. Yes. Okay, this also quite we have discussed in our workbook. Then, this is a straightforward question. Ectopic tissue in a Meckel's diverticulum, that is ectopic normal tissue in an abnormal site. We call that as a choristoma, no? Yes, choristoma is the normal tissue in an abnormal site. Yes, so the commonest tissues which you can see in a Meckel's diverticulum, it is a straightforward one. And out of these four options, gastric and pancreas, colon and pancreas, gastric and thyroid, gastric and colon, the correct answer is gastric and pancreas. This is a quite straightforward question. Then, partial aneuploidy is seen in, yes, we have discussed a lot about this aneuploidy in our workbook-based sessions, and also we have come to know that aneuploidy is nothing but it is a numerical defect. Okay, numerical defect. Aneuploidy means that is increase or decrease in one or more chromosomes. So it can be a trisomy or it can be a monosomy. So we have discussed in our workbook about this aneuploidy, and also we have also discussed about this Clyuda-Chatt syndrome. And we saw that there is a Clyuda syndrome, Chatt syndrome, what happens? There is a 5p deletion will be there. So a part of a chromosome, that is a 5p arm is getting deleted. So it results in a partial aneuploidy. So it is a partial aneuploidy. So partial aneuploidy, the answer here is the Clyuda Chatt syndrome. Okay, so the child will be having that cat-like crying, no, with the behavioral problem. So here, because of this deletion, because of this 5p deletion, partial aneuploidy occurs. Then the other question is technique for detecting low allele frequency. Low allele frequency is nothing but which is in a general population if that allele expression is very low. It is not a normal expression. the frequency of expression of that allele, if it is not a common one, it is not a common one, but it is expressed in a very low frequency, how will you detect? Which technique will be more helpful in detecting this thing? So out of this thing, the best molecular investigation, genetic diagnostic investigation for detecting this low allele frequency is the Sanger sequencing. Sanger sequencing, and we have discussed about the Sanger sequencing, which is as a gold standard. Okay, gold standard in diagnosis in our workbook. Okay, yes. Coming back to the other question in hematology, that is, all of the following are true about anemia of chronic disease except. So now let us explore one of the all of these options. So anemia of chronic disease and iron deficiency anemia, quite you have to compare and contrast these two diseases. So what will happen to the parameters? So usually the iron stores will be adequate. Okay, usually the iron stores will be adequate in anemia of chronic disease, whereas in iron deficiency anemia, iron stores will be lost. But what happens in anemia of chronic disease? It is the high serum hepcidin. The high serum hepcidin will be preventing the intestinal absorption. In anemia of chronic disease, the hepcidin levels will be more because of the chronic inflammation. The hepcidin levels will be more, and this high hepcidin will impair the intestinal absorption and prevent the release of iron from the macrophages. High hepcidin prevent the release of iron from the macrophages and impairs the iron absorption in the intestine. So there is definitely an iron deficient state. Okay, so iron levels will be low both in iron deficiency anemia as well as in anemia of chronic disease. But what makes to differentiate this between these two diseases, iron deficiency anemia and anemia of chronic disease? And in anemia of chronic disease, usually the total iron binding capacity will be low and ferritin levels will be high. Ferritin levels will be high, okay, in anemia of chronic disease. Whereas in iron deficiency anemia, because it is anemia, body wants to bind even a small amount of iron which is getting into the body. So it will have an increased total iron binding capacity and decreased ferritin. Yes. So coming back to our options, in anemia of chronic disease, total iron binding capacity will be low. So this is the correct option. Iron stores will be adequate. High serum levels of hepcidin will be there. And usually ferritin levels will be high in case of anemia of chronic disease and it will not be low. So this is the option we have to choose. Yes. Okay. So this is a quite, the next question is a quite simple and a very easy question also. And if you could remember our work-based session, actually we have discussed about this trophoblastic cells in this choriocarcinoma and about this markers in all this teratoma and all this ovarian tumors we have discussed in detail in our workbook. So based upon this, I think you could have made a diagnosis of choriocarcinoma. You will get a lot of in situ trophoblast. Teratoma, characterized by the presence of hair and cartilage, and also what you will be getting in teratoma, Rokitansky protuberance. Yes, Rokitansky protuberance. Yes, Rokitansky protuberance. Rokitansky Ashkoff sinuses, where you will be getting in chronic cholecystitis, you will be getting Rokitansky Ashkoff sinuses, but in teratoma, you will be getting this Rokitansky protuberance. Yes. Then yolk sac tumor, Schiller dual bodies. If you can see, actually with the Schiller dual bodies, 2 questions came. Yes, this exam, Schiller dual bodies, 2 questions came. And dysgeminoma, it is similar to like seminoma in testis, will have a lot of lymphocytic infiltration. So I try to match the things, diagnosis with the findings. Yes, this is a workbook based thing. We have discussed these things. And next is also a quite very easy and simple one. The match the following, and the easy one, all of this to get the option is the retinoblastoma RB gene. Yes, retinoblastoma RB gene. And the neuroblastoma is N-MYC. If you remember, I would have told you the mnemonic, no? N for N. You can remember, and if you can see our workbook, you can see that N-MYC, N for N, that is neuroblastoma. And the C-MYC, that is for Burkitt's lymphoma. C-MYC, that is Burkitt's lymphoma. So the new one which is asked is the pleomorphic adenoma, PLAG 1. Maybe in the subsequent exams, actually, this can be included in the future exams also, the trend. Okay, so PLAG 1 for this pleomorphic adenoma. Pleomorphic adenoma. Yes. So this also we could see from our workbook. Then The next question is actually based on image. The students were saying that it is a clinical scenario based thing, and the examiner has given some fish image and wanted to ask for the gene rearrangement. And if you could see that the picture, mainly the examiner was not asking you the diagnosis of the thing, and the examiner was asking you what was the technique used. And all of us, many of the students could tell that the technique the examiner wanted to highlight is the fish technique. Yes. So fish technique actually quite we have discussed about this thing, fluorescent in situ hybridization, and it is actually used with the help of a probe, fluorescent labeled probe. You could make a deletion. Many things can be there. Yeah, deletion arm can be made out, or even you can make out a additional loss, duplication, chromosome duplication can be find out, and also the fusion gene products like in Philadelphia chromosome. With the help of this fish technique, you can see that you can also identify the fusion gene products. Okay, like gene rearrangement, as some of you were telling that gene rearrangement like thing question was asked, you can see that such sort of things image would have been given. Like you can see this green signal for BCR, that is a normal one will have a separate two green signals, and ABL labeled as a red signal. You can see two signals here, but this is normal. But in Philadelphia chromosome, you could see that fusion of the green and the red signals. You can see the fusion gene product. Okay, so this is how I think the examiner would have given you the gene product, fusion gene product. Okay, fusion gene product, and also for the overexpression. So for overexpression, like NMIC overexpression in neuroblastoma, or the HER2 overexpression in breast carcinoma, you can detect. See, for in this case, HER2 new is gene is labeled with a red probe, and you can see the tumor cells how much increased signals in the red signals in this technique, fish, telling that a HER2 gene is overexpressed. So this fish technique usually can be used to identify the deletions or the, in this type of overexpressions. Okay, and also the fusion gene rearrangement. So all these things actually fish is a commonly used thing. Then the other question is like a boy presented with a low platelet with melena and atopic dermatitis. So what will be the next best investigation? And actually, I could not get more options from you people. Like actually, the two options which were like I could get is VASP gene mutation and antiplatelet antibody. So what we have discussed from this thing is workbook is actually it is a Wiskott-Aldrich syndrome. You have a triad of thrombocytopenia. Eczema, and recurrent infections. Yes, the examiner has given you that low platelet and eczema in the form of this atopic dermatitis. Okay, this low platelet will be the cause of melena. So in these things, actually, the first thing you have to do is this gene VASP. Okay, gene VASP you have to identify. So this actually about this Wiskott-Aldrich syndrome, the examiner was asking you. You have to suspect Wiskott-Aldrich when there is a low platelet with the skin lesions and the recurrent infections. If the history was given in the question, you have to make a diagnosis of Wiskott-Aldrich, and you have to see for the VASP gene mutation. Okay, so these are some of the questions like pathology related topics, pathology, core pathology, and the other core related topics. And what is the overall impression about these questions is actually, as I said earlier, there were many repetition of the topics were there, and like as I expected, as we discussed in the class, and as we stressed on some of the topics, very important topic, those repeated topics were asking, where the examiner was asking those things. And if you could see that there will be in every exam there will be some new topics definitely will be asked. Actually, when it is difficult for you, it will be difficult for everybody. So because that is a new topic, almost 99% of the people will not be having familiar with this type of things. So don't bother about the topic which was very vaguely asked or which has a confusing options. Don't bother about these things. But definitely, if you would have done the majority of the questions, which is a very repeated topic, and what we stressed in during our sessions, if you would have learned that thing, definitely you would have attended all these things. And take this as a practice for the upcoming NEET exams. So there may be a high possibility of asking or the repetition of the topics which was asked in the INI-CET. So I hope that in this discussion, I tried to explain you some of the facts. If you have any doubts or you want to differ from some of the options, you are always welcome to put it in the comment box. So definitely we'll be sharing the things with you. Okay. Thank you once again, and all the best for your results, and all the best for your upcoming NEET exams also. Thank you very much.